Thank you, Dr. Glover, for being here with us and for graciously accepting the invitation to come speak to our group, as I know you're a very busy person. So Dr. Crystal Glover is an applied social psychologist, mixed methodologist, and health equity and aging researcher at the Rush Alzheimer's Disease Center and an associate professor of psychiatry and behavioral sciences and neurological sciences in Rush Medical College. She also leads the Outreach Recruitment and Engagement Core at the Rush Alzheimer's Disease Center. Dr. Glover received her doctorate in social psychology and neuropsychology from Howard University and completed her postdoctoral research fellowship at Dartmouth Giselle School of Medicine. She was competitively awarded a BMO Harris Bank Health Disparities Research Fellowship within the Department of Preventative Medicine at Rush Medical College. Dr. Glover joined the faculty of the Rush Alzheimer's Disease Center in 2016. Dr. Glover's areas of interest include health equity and health disparities, structural and psychosocial determinants of health, intersectionality as a conceptual framework and methodology, and social cognitive processes. She focuses her research on related efforts on understanding and facilitating cognitive and healthy aging across all demographic groups, but with a special concentration on collaborating with and inclusion of communities that have been inequitably included and traditionally understudied in aging research. One of her NIH-funded research projects focuses on decision-making regarding brain donation among older adults representing racial, ethnic, and economic minoritized groups. Dr. Glover has widely published her peer-reviewed work in several high-impact scientific journals, including Alzheimer's and Dementia, the Journal of the Alzheimer's Association, Chest, and Human Genetics. She continues to present her research at international and national scientific meetings and belongs to several professional groups, including the Alzheimer's Association International Society to Advance Alzheimer's Research and Treatment, ISTART, and the Centers for Disease Control and Prevention, BOLD Public Health Center on Excellence on Dementia Risk Reduction. Overall, Dr. Glover dedicates her work to eradicating health disparities and creating equity globally, nationally, and locally. Please join me in welcoming Dr. Glover. Our virtual hands.
I know. Thanks so much for having me. That was great, Ishan. So good. And I'm happy to be here today to talk with you about sort of a series of papers that recently have come out during the pandemic about really highlighting protective factors among older adults. And I'm focusing on 3 sets of activities: social, physical, and cognitive. Oh, okay, I guess I'll just hit this button here. I have a new monitor. I came back from a trip this morning, giving another talk out in Vegas, and I have a cool new setup, but it's really the first presentation that I'm giving with this setup. So just working through that. So I kind of break up my talks in 3 phases. So at first I'm going to give you what I'm talking about in terms of health and disparities and really throughout the life course, but with a focus on aging. And then speaking about 2 intertwined sets of factors, both risk and protective. What's their impact? How do they work? How they're connected with each other, as well as other related variables. And how are we making meaning about this in terms of older adulthood? And then I think the most interesting part is our thoughts and questions that y'all may have once I'm finished. So before I really get started about the risk and protective factors, especially related to health outcomes in older adults, I always find it beneficial to define, what do I mean by health? Because a lot of times we may be speaking about simply an absence of disease or infirmity, especially physical health. But I'm really subscribing to the World Health Organization's 6 elements of health, where in order to have holistic or complete health and well-being, you're at least considering these 6 different elements. Of course, you're thinking about physical. That's something that's very important about our brains, health, kidneys, limbs, etc. But also thinking through, what's your mental or psychological health like? Your levels of stress, anxiety, depression, but also purpose in life and psychological well-being. Who are you able to interact with? How are those relationships colored, meaning your social environment, your social interactions? Where do these things take place? So say right now I'm back in my office, plenty of green space, well lit, running water, but what does that look like for others and how does it relate to my health? Intellectually, can I pursue my career, my education, unfettered, or at least in a way that I see fit? And then lastly, something that I began exploring at least a little bit on tangentially is spiritual health. So it doesn't have to really be connected to a deity of sorts, but how I conceptualize it is, what do you mean, or what do you think when you lay your head down at night? So all of these 6 elements take place within 5 settings of health. So in my publications, I really set forth that, of course, your health is alpha and omega, beginning and end for yourself. It's intrapersonal. So it's really, you're living it every day, but you're typically not living those things in a silo. It's an interpersonal relationship. So even today, you see your colleagues, you see your boss, you see others that you may be working with, and how are those relationships, I guess the nature of those, how do they facilitate your health? I'm speaking specifically around psychological and other pieces, intellectual, but they're also taking place within larger institutions. The 4 big hits that I really center in my work is healthcare, education, employment, and housing. So really, I treat neighborhood as an institution. But even though these things largely take place in big communities, where are they situated? Can I get to work okay? Can I grocery shop where I need to? Can I get to and from via sidewalks, public transportations, roads, etc.? But a lot of these settings are really informed by what I call the shadow boxers, or systemic settings of health. So if you join me all the way on the left, what I really speak about in terms of shadow boxers are the structural determinants of health. You have various policies such as the labor market, who is able to do what, how is it valued, how much is being compensated, who's able to live where, what are the resources in those neighborhoods in terms of space, amenities. That includes things such as up-to-date quality healthcare, food to purchase, fresh fruits and vegetables, running water, sidewalks, street lights, etc. But then also the institutions there, maybe a little bit more up-to-date, higher quality. But these things are all governed by, at their root, at the very bottom, culture and societal values. That's who and what we value. So in the middle here is a bi-directional relationship with these values, really informed by the crude demographics that we speak about, the big hits, race, ethnicity, gender, but also our socioeconomic status, which is informed by our years of education, what do we do, how much money we make. But I say that's really a crude evaluation for who has power, so who has the ability to make decisions for themselves, but also others, including us, and who has prestige. Just because you have power or prestige does not mean you have one or the other. But these things really flow into who and what we value. All the way on the right side is us, your everyday person trying to make it through with the social determinants of health, and how do they may have impact on our own health and well-being, but also more broadly equity. So with all of these elements of health, settings, different determinants, there's clear room for disparities. So simply put, disparities are simply an imbalance. But here, what I mean, especially with the Centers of Disease Control and Prevention, these are largely preventable differences, meaning they don't have to be this way. My work focuses largely on health disparities in relationship to opportunities, or the lack thereof, to achieve your optimal health. So optimal health in the sense of those 6 elements. So whether it's intellectual, so cognitive activity, social activity, or physical activity to inform your overall health. And these things are largely experienced by the people in the middle box on the previous slide that may lack power and prestige, at least in our dominant society. So think that for the overall United States of America. And something I focus on largely is in older adulthood, but this exists across all ages and within all age groups, but it's just a particular group that I'm really interested in. So in my work, in my presentations, publications, how I think about things conceptually, I don't see health disparities as a world apart or a field apart. These are things that are baked into our everyday health, the healthcare we receive, as well as the research that we do. So it's something that's in a constant state that we're experiencing, whether it's you in this particular environment or someone else, but it is a throughput in which we're doing our work. So one of the biggest health disparities or a critical issue that I describe is thinking about chronic diseases of aging, particularly Alzheimer's disease and related dementias. And I'm really concerned about the increased risk of developing, but also being affected by ADRD, especially among Black and Latino adults, and within those groups, women. So I speak about being at higher risk. So, research has shown that particular racial ethnic groups, but also being affected. And when I think about Black women, Latinas, I'm thinking about their role as caregivers. So being more likely to be a caregiver for a spouse, a parent, a child, even a neighbor is all community related as well. And what does this mean in their middle age for their own health, their finances, retirement down the line, and their own Alzheimer's disease risk? So I'm thinking of it in totality of not just at risk for the disease, but being affected by it in those other domains of health. So say psychologically, intellectually, socially, environmentally. So myself and others, of course, are really battling and thinking through how to eradicate health disparities and facilitate ultimately equity. So a big theoretical framework that I work within is NIA's Health Disparities Research Framework, is where we center these different priority groups, particularly Black and Latino adults across this life course. So if we think about it, ADRD just doesn't spring up when we're older. It's percolating earlier in our lives, and is really predicated upon these 4 big levels of health or factors related to health: biological, so that's very intrapersonal; behavioral, intrapersonal as well as interpersonal; sociocultural, community and institutional; and then environmental, which are shadow boxery, those structural issues that I speak about. And really interested in how these different levels operate independently, but also in collaboration or interaction with each other. But then I said, well, this is just huge. So big arm of my program of research thinks about these 2 intertwined sets of factors that's evident, whether it's biologically, socioculturally, whichever element of health, and they are risk and protective. So risk, of course, diminishes your health or your opportunities for optimal health, whereas protective factors are really things that may facilitate health, maintain your health, or improve your health, but really contribute overall to having healthy aging as you go along. Some protective factors that I really focus on, I'm going to be speaking about next, are focused on the 3 acts that I've published on. So social, physical, and cognitive. So social activity, that's going to be highlighted on the next slide. Physical activity doesn't have to be like weightlifting or CrossFit. It can be yoga, walking, gardening, any kind of frequent movement that you're able to engage in. Cognitive activity, mentally stimulating, reading books, magazines, engaging in conversations with others about current events. But also I really spread it outward recently, and I think this paper came out both of them just last month, February to be precise. How are these things connected to and informing 2 big protective factors: purpose in life, which I'll talk about as well, and psychological well-being. And I'm really interested in how they impact not just ADRD, because whether you develop dementia or not, you still have these other milestones along the way, particularly healthcare and financial decision-making, perceived stress, and risk of early death or mortality risk. So something that's really the hub here of the 3 acts is social activity. And as an applied social psychologist, I'm always thinking about non-pharmacologic ways that someone may be able to impact or decrease their ADRD risk, but not just that, but also being able to engage in healthy aging throughout the life course. So here, when I'm talking about social engagement or activity, it has to be meaningful, has to be sustained, and it has to be fundamentally beneficial to yourself and at least one other person. So that really excludes, a lot of people ask, does this include work, like what we do for work? And it does not, because if you're being paid for it, it is seen as not intrinsically beneficial. That's not to say you can't enjoy your work or work with people that you like collaborating with, but it just does not fit that definition. Really, it's the book clubs, gardening groups, yoga classes, etc., and spending those time with family and friends. So it's such a big thing that it has been named one of the 9 potentially modifiable, whether risk or protective, of cognitive impairment, but also one of the big elements of healthy or successful aging. So some folks have even postulated that if you put together social, physical, and cognitive activity, it can help decrease at least 40% of dementia cases. So that's really huge to think about outside of ApoE4, outside of getting older, outside of age-related cognitive decline. These 3 activities together may be able to reduce about 40% of dementia cases. And that's some of the work we see as well that I'll show you in a minute. So when I first began thinking about this topic, I wanted to know, well, does it really matter what takes place, say, at midlife going into older age? So we did this at 3 snapshots. So at first it is what impacts, say, from midlife to older age, dementia risk. So we're seeing the first finding is that nothing that we do in terms of social engagement at around my age or midlife has significant impact on dementia risk. But once you get into older age, that you will see that those who take part in frequent social activity have decreased risk of dementia compared to those who do not. But something I found interesting in this earlier work is that longitudinally, it's really about the decrease. So in order to see decreased dementia risk, you have to stay consistent from midlife into older age, as well as during older age in terms of your late life social engagement. So if you think about it, at 65 doesn't look the same as 75 to 85. So you must be consistent with your social engagement to have true dementia risk reduction as you age. So some work that my colleagues and I here at the RADC wanted to know was, all right, if social engagement is so important, no one has really delved into what this means for older Black adults, a particular population I'm interested in, but also what are the types of social engagement activities that one should be taking part in? And really the biggest outcomes or the biggest impact is of those engagements that are community-based, volunteer-oriented, and done within a group. So it's something that is facilitating health or something, a resource building for others. You're doing it in communities that you love or care about, and you're doing it with others who may be like-minded or with those who you care about as well. And that has a huge benefit, especially for reducing early risk of early death. So going back to that first paper and thinking through the midlife piece not necessarily impacting dementia risk in older age, but the consistency of being able to stay highly engaged socially as you get older. So some more colleagues and I took a look at what does this look like over time within older adults? So removing older age, but looking specifically in people 65 and older across about 15 years. And we were able to see that more social activity, of course, related to less cognitive decline. We saw that cross-sectionally, but longitudinally, that rate of decline was reduced by 70% among individuals who remain consistently socially active across these 15 years. So that's huge. So one of the mechanisms that we think of, as at least I think about, is, so we're engaging in these activities. how is it really getting under the skin? How is it impacting our cognitive impairment, cognitive risk, mortality, ADRD, and it's something that we postulate called cognitive reserve. And that's the ability for the brain to cope with any damage that may be existing there or pathology, so it's able to remain functional. You're able to continue to make decisions for yourself, remain relatively stress-free, as well as not be at risk for early death. So this is huge across the lifespan that we know, especially as individuals with ApoE4 risk gene, even if they had that ADRD risk gene here, if they were able to have the 4 markers of cognitive reserve, that's more years of education, engaging in complex work in midlife, having a large quality social network, and being able to take part in these social, cognitive, and physical activities that we see here as a leisure score, they were able to have a decreased risk of developing dementia. And upon really separating out, we saw that if they engaged more frequently in these social activities, that dementia risk decreased even further. So it's something about that cognitive reserve that we're seeing here that really may be the mechanism by which the 3 acts are able to impact these more biological outcomes in aging. So a big criticism that I've set forth in 2 recent papers, as well as others before me, is that social activity is just one component. I tend to think of social activity in combination with cognitive and physical. So as I say, the 3 acts. And sometimes I wonder about the independent impact of social activity on these different outcomes in aging. So I'm postulating here that, and others, that there's an interrelationship between them. Because if we think about, I'm an avid yoga practitioner. I go frequently to a studio with the same people. If I'm taking part in this more physical activity, if I'm engaging socially, and then I'm thinking through the poses, I may be thinking through different things in my life at that time, and then speaking about them with other practitioners, isn't that all kind of interconnected? So how do we kind of parse those things out, as activities usually have more than one component? So previous work is thinking about that same thing, independent and combined impact of the 3 activities on dementia risk. So to put it short, that if you engage in at least one of these frequently, meaningfully, the risk comes down a bit. If you engage in 2, it's like a little bit more. But the most dementia risk reduction, at least as I showed on the previous slide, more than 40 to 50%, is if you engage in all 3. So it's not an activity that has to have all 3 components, but if your life includes physical, social, and cognitive activities that are meaningful, regular, and consistent over time, that's the biggest bang for your buck. So we've talked a tad about the mortality risk and the ADRD or dementia risk, but my more recent work is focused on, well, if you're not dying early and you're not, say, developing dementia, you're still living, you're here, and there are things that are highly important as we get older, and nothing that I've seen is more important, at least on the more psychosocial end, has been on decision making, and that's particularly among healthcare and financial. So as we get older, we're having more health concerns. We may want to visit a provider more often, urgent care, community-based clinics, etc., but also making decisions about our finances in retirement, housing, etc. So how do these things move up to impact, say, different outcomes that will be taking place as we get older, no matter what occurs, whether we're developing dementia, whether we are simply experiencing age-related decline, or just living our lives, we need to make these decisions. So I wanted to understand how the 3 acts work together in order to impact this very important decision-making skill. And what we see here, something that I didn't hypothesize, was that late life cognitive activity really made the biggest impact on decision making, especially among people who are experiencing already cognitive impairment. So what that means is people that are consistently taking part in meaningful activities like reading, conversing current events, doing puzzles, maybe taking part in a museum or getting out more, are having, say, better decision-making, even in the face of cognitive decline or diminished cognitive function. So that's showing there that even in late life, that these different skills are able to bolster your decision-making in these two big domains. So here, I wanted to know if, are we speaking about something that's bigger than the three acts? So really thinking, putting on my psychologist hat in terms of purpose in life. Something that's positive, of course, where you have a general sense of meaning. So it's that spiritual, intellectual, and emotional health that I spoke of earlier, where you're really invested in your own life's experiences. Unfortunately, I did not see a direct effect with decision-making here, meaning that regardless of where your purpose in life is, doesn't have an impact on your decision-making. However, if you were experiencing diminished cognitive function or diminished cognitive capabilities, being able and having more purpose in life was able to bolster your healthcare and financial decision-making over time. So I said, well, purpose in life is simply one element of psychological well-being, which I think includes also not just purpose and other domains, of course, but your engagement in positive activities with others, being able to get out and explore new things, being curious and really taking on the robustness of your life and saying, you know, life has its ups and downs, but it may be generally good. And knowing that psychological well-being is associated with decreased mortality risk, longevity, but also disease and disability-free longevity and better mental health as we age, I wanted to know, can we back it up a little bit and say, how is it impacting things, outcomes along the way, including decision-making? And we saw that direct relationship between this type of well-being and decision-making, but particularly among people with lower cognitive function here. So if you see a trend that even in the face of diminished cognitive capabilities, these psychosocial factors are showing to be protective of brain health and related outcomes in aging as we get older. So I did say that we were going to talk a little bit about risk. It's not my favorite thing. I haven't published the most on it, just a tad bit. I would say the last 8 or so papers have focused on the protective factors, but I would be remiss if I didn't indicate how social engagement and loneliness can coexist. Just because I'm engaged socially, frequently, meaningfully, does not mean that I do not maybe go home or experience loneliness or being socially isolated from others. And I have done a little bit of work in that area around decision-making, such that, of course, as anticipated, the more lonely you are, especially those who are experiencing cognitive impairment, are making poor healthcare and poor financial decisions. And I'm exploring, especially among older Black adults, that the mechanism by which this may be working is perceptions of stress. So it's not surprising that individuals that may be experiencing more loneliness and isolation are more likely to feel higher levels of stress that may be linked to that mortality risk that we spoke about in a previous study. So in summary, I will say that, of course, social engagement should be encouraged, not only for your cognitive health, but really for health outcomes overall, especially as we get older. And it's important to maintain these things, not just into older age, but throughout older age. So I think that's an important distinction. And social activity is likely interconnected with cognitive and physical activity, of course. Something that I'm working on now, have a grant under review. I did all of this work here as almost preliminary data for an MDI, a multi-domain intervention, focused on, particularly among older Black and Latino adults, how can these 3 types of activities really inform EBPs, or evidence-based strategies, and interventions to say what's the least amount or the bare minimum these busy seniors can take part in that may bolster not only decision-making and mortality risk, but also dementia risk. And something, of course, that's in the grant here is I call attention to 2 big populations that I think we need to focus on, especially in older adulthood. That's Black and African-American people, especially if we're setting forth that they're at increased risk for dementia. And really in my other work, really interested in non-pharmacologic ways to help bolster their health, how can these 3 activities really inform that? And how can these other, I guess you could say, factors that include immigration, migration, how does that impact social activity as we're not growing older in the places in which we grew up or went to school or where we work? And if we're saying that workplace and midlife is important, what does discrimination look like with that impact in developing those relationships? And of course, these two intersect, of course, here, women are not, separate from African American, Black, but keeping it 2 large groups of individuals, and also thinking about women in terms of caregiving, their trajectories to cognitive impairment, but also what does it mean to have more stagnant financial resources, being isolated in midlife into older age due to the role of caregiver, and how does that impact the 3 acts as they get older? So I'm setting forth in a paper under review right now, as well as a grant on how we can strategize to identify populations of interest, different activities that are already going on because communities are resilient, they're thriving, and they're usually ahead of the curve versus us, as to what are they doing, how can we help them with those things, really strategize and develop these RCTs and intervention strategies to take it even more broader than the community-based, especially created and tailored for them. So this really goes into the directions of those papers and grants. Well, the 2 papers are under review. It looks pretty favorable, and really looking at these activities, these interconnected factors exclusively among older Black adults, with that really focus on psychological well-being as another mechanism for better cognition as we age, decreased dementia risk, and lowered mortality risk, and really looking to introduce that taste of intersectionality, particularly among middle-income Black women as we explore the 3 acts. So something I'm aiming to do through my work is moving us from disparity, of course, and even out of equity, where we have these custom tools, but really to eradicating these impediments to realizing our full health, those 6 elements, and how we can think of aging more holistically and just not the absence of disease or early death. So acknowledging everyone here at the RADC, my funders, of course, and I hope we can have a good conversation about what I talked about. Hope I didn't move too quickly. Wanted to get it all in there, but I'm open to questions about how all these things link together and the machinations in each of the studies. So thank you.
Well, thank you, Dr. Glover. You see my little hands in my corner of my my square there, just to thank you for such a fascinating talk. You did cover a lot in a short amount of time,
Yeah.
but I love the idea of having an open discussion. So I'm gonna just sort of facilitate the question and answer and see, as people would like to ask their questions. Do we have someone who would like to go first? Carol, yeah, I see you. You're my top Hollywood square.
Oh, I'm so glad to be there. I have a bunch of questions, but I'll just start with one and let other people after that. But thank you. That was a really great talk. So my first question is, especially since it's the change in social engagement over time that seems to matter, how do you sort out lack of late life social engagement predicting dementia from it actually being a symptom of incipient dementia?
So that's an excellent question. So right now we're exploring that longitudinally. So we had a signal in some of our work from 2011 that even over time that these fluctuations or consistency was being related to cognitive decline. Okay, so we can see that decline, but we see this moving here. Now we're taking a look at, say, longitudinally with the 3 acts, and then how do these things change in relationship to each other more than 5 years, but really over the life of, I think it's about 25. So it's thinking about going from 65 all the way to 25 more years. So folks that have lived that way, but then being able to explore as the individual moves into whether impairment, decline, MCI, or ADRD, and seeing what are the different profiles of individuals that may have been engaging in those 3 acts and how they may develop or not ADRD, MCI over time. So seeing that relationship in relationship to each other.
Thank you. Do you think that if you could enforce increased social interaction, that you could prevent some of that?
I wouldn't say enforce. I would say maybe encourage with that yes, I do think we can, but I do think it wouldn't just be by itself. I do think it needs to be cognitive and physical together. And then something that we've been exploring here, and I say we, just meaning collaborators, is that what does it look like for other groups to engage in cognitive, physical, social activities? I think there's a huge shortcoming in some of the measures in terms of what may be meaningful for different groups of people, and not only based on race, ethnicity, but by age. Because a lot of the work, even with the measures, we're really thinking about and developed upon people who are 60 to 70. That may not look the same once you're 75, 80, etc. So how are those things more nuanced in terms of dementia risk, mortality, decision-making, and how can we leverage those together? So it's really 2 big things at one time. You know, what's meaningful to groups of people, how do they evolve over age, and then how do they impact these different outcomes in aging?
Thank you.
Others, please chime in. Any other questions or thoughts?
I have a bunch more
Yeah, I
questions.
thought I saw you.
Did you have a question? Go for it. Otherwise, I'll just keep going.
Go ahead, Heather.
So I'm not a social scientist, and forgive me if this is a really ignorant question, but what really is when we talk about social engagement, is it really interpersonal relationships, or is it something that I guess doesn't require that degree of like consistency of person? Because you mentioned like going to your yoga class and seeing the same people and over again, but is getting out there and socially interacting without creating like a long-term bond with people the same thing?
So it is and it isn't. So the one key piece that stays the same would be consistency. So consistency is there, but then it has to be an activity that is meaningful and beneficial to you. So if you think of, say, especially in the mortality risk work that we're doing, these different community-based, volunteer-oriented, group-related activities, the group may change. You know, you may only have 4 people show up versus 10 or only 2, but the mission is there in terms of it's impacting, say, others, something that they think is meaningful to them. They're with others who share a similar view on these sorts of things, and they see it as beneficial and is still consistent. So there is some argument that does it need to be the same people? Likely not, but does it need to be beneficial and regular, as well as something that you're at least interacting with one other person on? Yes, those are the basic ingredients, but the person is likely to change, especially across, say, if we're thinking about that earlier finding that you must remain consistent in between mid and late life. Those people aren't remaining the same, you know, but our interests may be the same and evolve, and we're able to take part in those with others who share that as an interest as well. So it's really those core ingredients versus the person itself, if that makes sense.
Any other questions before I call on Carol? No. It's okay, Carol, go ahead.
Nobody else?
I don't think so.
All right, jump in. So I'm just thinking about the work social engagement thing and not counting work as social engagement. And I think that's really interesting because, I mean, there is some data now showing that people who retire earlier have increased risk of dementia.
Yes.
And I know for me, although I have a social life outside of the lovely people I see on the screen, I really value the social engagement that occurs at work. And so it's kind of, it doesn't seem surprising to me that when people retire, there has to be some kind of shift in their social engagement, and it may take some time to re-up their social engagement after they retire. So I'm just wondering about the decision to say work does not count as anything towards social engagement.
I wouldn't say it does not count anything towards it, but I am in agreement with you, Carol, that this was all pre-pandemic that this sort of thinking was there. So what I mean by that is typically it's not involved, but as we're growing more into midlife, going into late life, some of the biggest places where people have their meaningful relationships is in the workplace. That's why it's so important in terms of women as caregiver. That's what I kind of alluded to in being affected by. If you're taken out of the workforce or if you're having diminished role there, it could truncate your ability to develop those long-standing relationships, especially in terms of maybe being divorced or being widowed, etc. How do we carry that forward? So some of my own work that I have percolating now is exploring that. So the original definition, no, it does not include that, as is you need to be able to take finance out of it, or being able to have that reciprocal kind of financial relationship, like I'm doing the work essentially for a particular amount of money. So we need to remove that from there. But I think also it also depends on the type of work we're considering, the type of social engagement. And then also it has been some literature on folks that may engage in social activities, but maybe taking part in more risky behaviors. So I think that needs to be explored, as well as in what takes place when we're engaging with each other, but also what is the role of work and workplace relationships in terms of us, especially going late life. Because I do think our initial definition here, one that I helped develop with the CDC and we're looking to revamp it, is that it looks at employment in terms of employer-employee, but it's institution-employee, but not between the two people. So the person I'm working with and that I'm enjoying working with is not the person who's paying me. It's the institution. So really delving into those nuances that you bring up, I think are very important, because I think we're taking a more structural view of workforce relationships versus that more interpersonal. I think that's because for a long time, a lot of the MDI work, the multi-domain intervention work, people have criticized it for being very micro or person or individual related. I didn't see that as a big critique, because we're all working within these structures. There are researchers and others that are working at the larger or macro level, but we don't need to impose that on every type of relationship. So that's something that I'm interested in as well. But I fully agree, because some of the people I've met at work are now, my personal friends, and I think about that in terms of what that may mean for other, not saying no one else, but other women in particular, as I'm very, focused on my own identity as a woman, and we're great friends, even as we move around. So yeah, I agree.
And then can I ask just one more quick question?
Yeah.
The work on psychological well-being being directly related to decision-making is really interesting. How did you measure psychological well-being and decision-making?
Yeah, so that one we adapted from Riff's work, her big 6 domains of psychological well-being, one being purpose in life. And then there's another domain that really encapsulates those 3 activities that she set forth. So that's psychological well-being. And then for decision-making, we worked with the Federal Reserve to understand what are the big elements, basic 8th grade level, for being able to make healthcare. So say insurance. So how can you select insurance, especially after you've retired, how you're able to make sense of what you're owing, also making sense of when you may want to see a physician or a provider. And on the financial side, how you may make decisions about your house, in terms of, do you want to downsize, in terms of moving, how much will you save if you did that, as well as do you have any investments or living on a fixed income. So it's 12 healthcare items, 12 financial items. They have 2 domain specific scores and then an overarching decision-making score. So higher scores, better decision-making in both domains.
And how did you control for the impact of education on decision-making or previous change in decision-making relative to previous levels?
Yeah, so we did control for age, gender, and years of education. So we did control, because years of education is huge, but full disclosure, so this was in our memory and aging project. So these individuals are averaging at least about 15.7 years of education.
Okay.
So they're
highly educated.
Yes, they are.
Uh-huh.
And even the older Black adults that we work with are about 14.8. So that goes back to questions of, and Ishan and I have had these so much, who exactly are we engaging in terms of research? Because separate from the 3 acts here in this other paper I have, I'm setting forth, and myself, other colleagues, we're talking to people who are seeing research as another type of activity. They're not keeping it separate from physical, social, political, etc. This is something that they have the time to take part in. In their older age, they don't have to worry about basic needs. And they are also living in neighborhoods that have lower levels of any violence, more safety, assault, etc. So researchers across the board are thinking about who exactly are we speaking to in terms of these different studies. But yes, it is huge. And then also, most of these participants are women. So, and I believe about 73%, and that's whether it's Black, white, Latina, Asian, it's just women, for many reasons that we've talked about. But yeah, they are highly educated. But even still, this is cross-sectional, but with some of our longitudinal work that's coming out, we are able to see that even among those individuals that are taking part in these more frequent social activities, even as their cognition kind of declines, over time, that if they stay consistent, then their decision-making may not improve, but it is maintained. So that's the big part, is it doesn't necessarily become improved, but it does stay at least static.
Thanks. And yet those are the same, well, because you talked to Sean, those are the issues that we grapple with as well, and really want to understand not just our college educated women who really want to participate in our research. So it's an issue.
It is.
Could I jump in with a question real quick?
Yes, you can. I apologize. I had a quick call there. I'm sorry. Go ahead, Sophie.
So thank you so much, Dr. Glover, for your talk. It was great. I'm curious how you've seen decision-making overlapping with some of the other sort of cognitive constructs that you're mentioning, and more also with subjective cognitive decline or even mild cognitive impairment, and how the risk factors and protective factors that you mentioned might also be related to subjective cognitive decline, and how that might sort of overlap with risk for decision making.
So the SCD, that typically gives the signal before any sort of MMSE or any type of cognitive test. But we were really interested in, especially me and a neuropsychologist here, cognitive neuropsychologist, Melissa Lamar, in focusing on what is the benefit of psychological well-being or purpose in life, but really psychological well-being, and thinking through how even in the state of these diminished cognitive functions, is that it may not necessarily be just what does the psychological well-being mean? It may be giving people this more confidence in terms of being able to still go out and engage with others about, so as Carol mentioned, that how do you really make that distinction? But it's what does the construct mean itself? That if I'm experiencing these higher levels of psychological well-being and I'm feeling more engaged in my life, I may have other folks that I can call upon to float these healthcare and financial decisions by. Or I may have more people that are also experiencing disease and disability-free longevity that I can engage in these physical activities with or conversations with. So I think even in the face of SCD, and we haven't looked at this, that able to talk with someone else, a peer that we see is very important in being able to say, do you experience this? Do you think this is normal? Or would you go see someone at this stage? I think that's highly a more, I guess, tangible mechanism in which these constructs may be working. And I also think here that's important for the subjective piece in being able to bounce these ideas off of others. And then if you do still feel that way, taking it to a provider to understand your cognitive status.
Thank you.
Thank you. Travonia, did I see your hand? Did you have a
Yes,
question?
I did.
Oh, okay.
Just a brief question. And thank you so much for your talk, Dr. Glover. It was excellent. I just wanted to know, how do you tease apart that those who are more socially engaged are generally healthier, a healthier cohort of individuals versus those who are not as socially engaged simply because of physical limitations, they may not be able to be. And then also too, you talked about the effects of different physical activities on level of decline, but have you teased apart when you talk about or use the term activity, physical activity versus, let's say, mentally stimulating activities? So I may not be able to participate, outside of my home with my colleagues or with a group of friends doing something like participating in a walking club. But maybe I enjoy bridge, or maybe I enjoy playing chess, or, could if I do this consistently, would the effect on my level of cognition still hold over time?
Yeah. So that second question, great questions. You're really speaking about benefit conferred. And I think that is something that's worth exploring, is what is the exact benefit conferred that you may not be able to take part in, various physical or whichever type of activity, but the one that you are able to has such meaning and such value that yes, it may confer even more benefit or protective factor over, say, other health outcomes, cognition, etc. I think that is worth exploring. I have not done that, and I'm not aware of work that maybe is doing that. However, the first question I think is just as important and interesting. And, I have been surprised at people with physical and other limitations being able to engage. And especially among older Black adults, and some of the work that mortality risk paper this was something I failed to mention, this was even in the face of increased cardiovascular risk factors and motor as well. So being able to move about, that individuals at least being able to take a walk or even just get out and about with different friends was very important. But something else that I think really deserves a note here is that the pandemic helped us understand these different types of activities, that even folks that may be more homebound were suddenly even more so discovering digital connectivity. And so that's a paper that we have under review now, that in the age of COVID, especially for individuals that may be in, as we define, poor health in terms of, say, mobility, what did that look like? And we are seeing that people that, one, had access to these digital mechanisms, but also using them in order to connect with others, read, say, more beneficial, or at least getting them up to date in terms of information on certain things, they were able to maintain decision-making during the pandemic. So it is something about whether you're experiencing physical, cognitive, other limitations, engaging in these activities, particularly over time, and with the advent or the use of digital aspects is huge. But then the huge limitation that we're thinking about is, even in Chicago, is there a complete technological dead spots? like huge neighborhoods that do not have Wi-Fi. You're unable to, even if you pay for it. So what does that mean? And some of our participants reside in those dead zones. One thing I also want to note is that what we did explore in one of the papers, I think it was Carol who asked that question, was the high education piece. And something I don't want to conflate that we spoke about, I can't remember, I think it was the three of them, the cognitive social physical activity paper in 2021, that just because you have higher years of education does not necessarily mean that you may have this improved or higher level of decision-making around these aspects. And the reason why we spoke about that, especially among older Black and Latino adults, is the relationship contextually and sociologically in the relationship to, say, healthcare and financial institutions. So even having the higher years of education, you may not just be as comfortable interfacing with these different institutions, and your confidence in making these decisions may be more intuitive, and maybe the folks you're speaking with may not have that experience as well. So we kind of talked a little bit about that in a few papers as well. It just popped to mind. There's so much going on that I forgot that little piece that we explored.
Well, again, thank you so much, Dr. Glover. This has been super helpful, and really enjoyed it. I know we're real hands in virtual space, but respecting everyone's time and yours as well. Would love to have you back at another time to continue talking about where your research is going, because I didn't ask my question, but it was going to pivot you to talk more about decision making with brain donation. So I saw you gave a talk about that recently, and I was like, oh my gosh, that's so interesting. And you know, the line of work that we were asking those similar questions here in Virginia about brain donation. So happy to see your work, or at least you had a talk. So I'll have you back to talk about that a little bit later. But thank you once again. And for those on the call or on the Zoom, this is going to be available. The slides will be available on our YouTube channel, I believe it is. So Amy or Anna can get you connected if you'd like to have the follow-up on these slides. So thanks again, Dr. Glover, and I bid you adieu.
All right. Thanks for having me, y'all.
Thank you,
everyone.
Dr. Glover. Bye-bye.
Bye.